Assalamu alaikum.
Waalaikumsalam warahmatullah.
Good morning.
Good morning.
How are you? Alhamdulillah. Are you okay?
Alhamdulillah.
Alhamdulillah. So how many presentation do we have today?
We got
Sorry?
1, 2, 3, 4, 6 presentation.
Okay.
Okay.
Okay, so let us start by Al-Kitab and go ahead for the first skill.
Okay, so can everyone see my slide?
Yes.
Okay, so Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Nur Shafiqah Binti Bakhtiar, and today I will be presenting on electroencephalogram, or known as EEG. So first, wait a second. Okay, so this is the outline of my presentation today, where I will begin with the introduction, followed by components, mechanism, procedure, EEG waveform, and the last one is the montage. So first one is the introduction. EEG is defined by an electrophysiological technique for the recording of electrical activity arising from human brain. And the general mechanism is by picking up the charge of the electrical potential, and it detects the neural activity of the brain, which is the summation of the excitatory and also the inhibitory postsynaptic potential of relatively large group of neurons that fire synchronously. And EEG is considered as safe procedure as it does not cause any discomfort or any sensation, as well as there is no risk of getting an electrical shock. So next, the indication for EEG. So basically, EEG is used to detect problems in the electrical activity of the brain that may be associated with certain brain disorder. And the measurement given by an EEG are used to confirm or to rule out various conditions, including seizure, epilepsy, head injury, encephalitis, brain tumor, encephalopathy, memory problems, and also sleep orders. Note that EEG also is used to monitor the depth of anesthesia during surgical problem. This is to monitor the potential complications such as ischemia or infection during anesthesia during surgery. So basically, we have two types of electrode placement for EEG, which the first one we have where the electrode are placed separately on the scalp, and the other one is that the electrode is mounted as special band on the head. So next, okay, so next is there are factors that may interfere with the reading of EEG tests, which include hypoglycemia, body or eye movement, light, drinking coffee, drinking drink that contain caffeine, such as coffee, cola, and tea, oily hair, or the presence of the hairspray, medication, and also anti-epileptic drug, which is given in high dose. So as for the complication, basically EEG rarely cause complication, but if it causes complication, it may cause a seizure in patient with seizure disorder. This might be due to flashing of lights or deep breathing that may be involved during the test. So next, moving on to the components of the EEG. So the first one is electrode. Electrode is a small metal disc, usually made of stainless steel, tin, gold, or silver that is coated with silver chloride. And it is then placed on the scalp according to the International 1020 system. So basically 1020 system is the standard method of measuring the head and placing the electrode in EEG. So it depends on the form and position of the head, which is the first one is the Nessian, and the next one is Indian, and also the right and left preocular points. So first, the first diagram, considering this diagram is looking from top of the head, and the second diagram is that we make a midline measurement, which is from the Nessian to the Indian. Then on the third diagram, we divided the midline into 1020 percent increment. Does this give name to the system, which is the 10-20 system? So then we mark where the measurement is made. Next, we measure the measurement is made between the right and left preauricular point, and then it is also then divided with 10 to 20% increment, and then we mark the measurement. Then the mark is made on the circumference of the head and separated by 10% increment, and then we make a parasagittal marks, and they are separated by 25% increment. So once the mark have been placed, we can place the electrode according to the position. So next, basically, the electrodes are represented by letters and number. So as you can see, sorry, as you can see, the odd number are on the left and the even number is on the right. So, and also lower number is placed closer to the midline and the bigger number is placed more laterally. So as for the letter, Z means 0, which is equals to midline, F means frontal, C means central, and P means parietal, and also T means temporal. And this you can see the placement of the EEG with the 10 to 20% increment. So next we have amplifier. Amplifier is basically an electronic device that increases the power of a signal. This is by taking energy from a power supply and controlling the output to match with input signal shape, but with a larger amplitude. So basically human brainwave activity is too subtle for us to read unless they are amplified. So the current technology used in EEG is they use the differential amplifier, where they take two electrical input and display it as the output as the difference between the two input. As for example, we can see the diagram on the right here. Basically, we can see that these two waves are basically the same, except for this small difference. So after they go through the amplifier, so only this small different signal will be displayed in EEG. So next we have filter. Basically, filter is interpretable EEG tracing, which I will be explaining later. And the last one we have the writing unit, where this will display the result of the EEG. So in this picture, we can see there are electrodes, there are amplifier, and also there are a monitor to display the EEG. So moving on to the mechanism of EEG. So basically, there are firing of thousands of neurons synchronously that generate an electrical field. And this will then be detected and measured by the electrodes. The signal is then passed through the amplifier, where through the differential amplifier, it will measure and amplify the difference between the active electrodes and also the reference electrode. Next, the signal is transferred to the filter, where in filter, they transform the signal from EEG time domain into the frequency domain. This will then remove the artifactual frequency, which may be caused by muscle or scalp movement. And then after they have removed the artifactual frequency, they will transform back the signal into the EEG time domain. And then they will pass through the recording and we can read the EEG result. So next is the procedure for EEG. So as for pre-procedure, first we need to explain the procedure to the patient and ask for consent, and also ask the patient to shampoo their hair, but ask them to avoid using conditioner or any hair care products such as hairspray or gel, because this can interfere with the EEG result. And then we need also to attain all the medication information that the patient have been taken, and also ask the patient to avoid consuming any food or drinks containing caffeine for 8 to 12 hours before the test. And also, if the EEG test require the patient to sleep through it, we need to advise the patient to reduce the sleep to 5 to 7 hours the night before. This is for children. And also, we need to advise the patient to avoid fasting the night before, because we want to avoid hypoglycemia during the EEG procedure. So next is during the procedure. You can read it in detail by yourself after this. But I want to emphasize the point that first we will observe the patient when they are in relaxed position. After we have recorded the EEG measurement in their relaxed position, we will then ask the patient to make some movement for us to record their brain activity next. So post-procedure also you can read it by yourself too after this. Okay. So next we have EEG waveform. So basically we have 4 types of EEG waveform, which is the delta, where the frequency is less than 4 Hz. And it have the highest amplitude but the slowest wave. And it is normal as dominant rhythm in infants up to 1 year and in stage 3 and 4 of sleep. And it can occur focally in subcortical lesion, and it can occur in general distribution in diffuse lesion, metabolic encephalopathy, hydrocephalus, and deep midline lesion. And for theta waveform, the frequency is 4 to 7 Hz, and it is classified as low activities. And it is normal in children up to 13 years old and also in sleep. And it will be abnormal in awake adults. So the manifestation of focal subcortical lesion and also seen in generalized distribution in diffuse disorders such as metabolic encephalopathy and also hydrocephalus. Next, we have alpha wave. It is best seen in posterior regions of the head, and it have the higher amplitude on the dominant side, and it appears when closing the eyes and relaxing, and then it will disappear when we open the eyes or we are in anxiety. And then it is a major rhythm in normal relaxed adult more than 30 years old. So we can see for adult more than 30 years old, the normal rhythm is the alpha, but for normal children up to 13 years old, the normal wave is theta. Next, we have beta. Beta is described as fast activity, and it is seen on both side distribution and mostly in the frontal area. And it may be absent or reduced in areas of subcortical damage. And it is a dominant rhythm in alert and anxious patient or with their eyes open. So it is opposite to the alpha wave. And it is also accentuated by sedative drugs such as hypnotic drugs. So basically the last one is the montage. Montage is basically how the EEG will be displayed. So first, we can see for the first chain we have over here, for this wave, it is referring to this left temporal chain. Sorry. It refers to this left temporal chain. And then the next class of the wave is referred to the left perisagittal chain. And then the next group of wave is referred to the midline. And then the next wave is referred to the right perisagittal chain, and the last one refer to the right temporal chain. So basically, this montage is known as anterior-posterior bipolar montage, and it is the most common and also the standard montage used in EEG. Okay, so these are my references. That's all for me. Thank you.
Good, Shafika. So what is the indication for EEG? Okay.
Yeah, this is the indication for the EEG.
Yes. There is a famous one with encephalitis, especially with herpes simplex. You need to present it. Okay. Good. Okay. Is it clear now to us that our procedure now sometimes may be propagated with time to be intervention treatment? I mean, the same idea of ECG, we are doing electrocardiogram. Sometimes you are using the DC shock. Okay, it will be the same idea and the same procedure, but we are going a shock if the patient has like ventricular or tachycardia or ventricular fibrillation. Now they are using the same idea also of giving some shock in case of severe bipolar depression or like that. Sometimes they are using also some shock therapy or electric therapy. So to know the idea is very important. It will help you with time to propagate your ability in medicine, because we are thinking for every patient as if he is our lovely person. And I need you for all your life to feel that, please. If you saw child, consider him as your baby, your own baby or your own child. If you saw someone in your age, deal with him as if he is your brother or sister. And if you saw one elder than that, just to proceed with him as if he is your father or mother. At the time, you mean what is Allah said about the Prophet, وَمَا أَرْسَلْنَاكَ إِلَّا رَحْمَةً لِلْعَالَمِينَ, means you are, for everyone, you are giving a benefit. For everyone, you are rahmah. For everyone, you are mercy. For everyone, you are a helper. That's why we are speaking now for simple procedure, but with time, we are able to propagate this to be treatment, and we are thinking about the idea, then we are trying to define the position. Now, if you are able to present the focus of epilepsy, are you able to use laser to treat? There is a lot of idea and thinking. So concentrate in that basics. I know that it may be a bit far from your career in year 3, but at least you put your hand, inshallah, on that important issue. Good. Do you need to ask any questions? Okay, let's go for the second presentation.
Assalamualaikum warahmatullahi wabarakatuh. My name is Zulwakar bin Abdul Halim Hafiz, and I will be explaining about washing and PPA level 1, 2, and 3. Before that, I hope you guys can see my slide. Okay, what is hand washing? Basically, hand washing is a hygiene, which means we wash our hand, we clean our hands by using hand wash with soap and water, or we can do other alternative by using antiseptic or hand rub. And it's important to clean our hand. So why we should wash our hand? Because hand is a very important organ that we touch everything in the environment. We touch our own body, especially in healthcare workers. We'll touch the patient also. So there are a lot of bacteria, organism live in our hands. So by washing our hand, it is important to reduce the spread of potentially deadly germ patients, or it can protect us as a healthcare workers from the germs that we get from the patient. So when we should wash our hand, this is basically a very important, and if hygienic persons, we should already know when we should wash our hand. It is common sense before and after eating, after using toilet. But our main concern here is from WHO. WHO stated there are 5 moments that we should wash our hand or keep hand hygiene in the healthcare setting, in the clinical setting. First is we should wash our hand before touching the patient, because it is the patient from germs that is on our hand. Second, we should wash our hand before any procedure, especially in clean and aseptic procedure, to protect the patient from harmful germs, including his or her own germs from entering into their body. Third, we should wash our hand after body fluid exposure or risk, such as in the when we contact the blood or patient discharge from the respiratory discharge, we should wash our hand. Fourth, after touching the patient. And the fifth one is after touching patient surroundings, including the beds, the instruments, the tables, because it's to protect ourselves from the organism that may present from the patient. Okay, basically, there are 2 alternatives, either by wash our hand or hand rub. So we should, the guideline, we should wash our hand when there's visibly soiled, when there is visibly soiled, when our hands are dirty, and when we should hand rub if there's no soiled. Okay, there are 11 steps in hand wash. I will show you the video later. But basically, first we should wet hands with water and then apply enough soap to cover all hand surfaces. And then we should rub our hands palm to palms. And then from right arm, interlacing the fingers interlacing between each other. And then the palms over the dorsum, interlace fingers and vice versa. And then we should back to back fingers, opposing palms. And then we should rotate and rubbing the left thumbs and the vice versa. The seventh step, you should rotational rubbing backwards and forwards to inspect fingers, right and hand left, and the vice versa. And then we should rinse after that. At the eighth step, we should rinse hands with water. And then we dry our hands with single use towel, and then use towel to turn off force. And then our hands are cleansed now. I'll show you the video later. Okay, basically this is how to wash our hands, and second step is how to hand rub. You can do it by your own. Okay, second, I will talk about personal protective equipment, PPE. So what is PPE? It is specialized clothing or equipment worn by an employee, especially healthcare worker, to protect from infectious materials, according to OSHA. Okay, among the PPE available in healthcare settings, including gloves to protect hands, gowns and apron, protect skin or clothing. We have masks, either surgical mask or N95 mask to protect mouth and nose. And then we have respirators to protect us from respiratory tract, from airborne infectious agents. And then we have goggles or face to protect eyes, mouth, nose, and nose. Okay. Okay, people, we have level 1, level 2, and level 3. For level 1, when there is no suspected or infectious agent, so we should use standard infection precautions by using disposable apron, gloves, and if there's anticipated exposure to blood or other body fluids, we should apply for surgical mask and goggles or face shield. For level 2, divided into 3, contact, droplet, or airborne. There are different clinical scenario according to levels. Okay, for contact, when there's suspected or confirmed infectious agents spread by direct or indirect contact, such as in Clostridium difficile, hepatitis C, MRSA, that can spread through direct or indirect contact. So we should apply for disposable apron, gloves, surgical face mask, and face shield. For level 2, droplet, suspected or confirmed infectious spread by droplet routes such as whooping cough, influenza. So we should apply apron, gloves, face mask, and face shield. For airborne, there's suspected or confirmed infectious agents spread by airborne route. So we should apply apron, glove, and 95 respirator mask or face shield. For level 3, is when we are doing aerosol generating procedures, AGP. In AGP, we should apply for FP3 respirator or powered respirator and eye protections. The clinical scenario for level 3, when there's suspected or confirmed infectious diseases of high consequences, IDHC, either spread by direct or indirect contact, such as Ebola virus, or airborne, such as MERS, COVID, SARS, or avian flu. So recommended PPE that we should apply in level 3 level clinical setting. First, we should wear fluid-resisting long sleeve surgical gown and apron, and then we should wear a fluid-resistant hood, and then N95 mask or a power hood, a respirator, and then we should wear disposable face shield, and then 2 setting of glove, long glove, and then surgical Wellington boots and disposable covers. Okay, this is among the aerosol generating procedures, including endotracheal and extubation, airway suction, tracheostomy, high frequency expiratory ventilation, and others. Okay, how to apply PPE? First, we should remove all of the personal items such as phones and jewelries. Second, we should put on scrub suit and rubber boots in the changing room. Third, we should move to clean area at the entrance of the unit. By visual inspection, ensure that all sizes of PPE set are correct and the quality is appropriate. Fifth, we undertake procedure for putting on PPE under the guidance and supervision of trade server or colleague. And then this is very important before we are doing PPE or donning, which is perform hand hygiene. And then we should put on gloves, and then we wear a gown and put a face mask. After that, we should wear for a shield or goggles, and then put on head and neck covering hood, surgical hood that cover the neck and the head. And then we should put on disposable apron. And last but not least, we should put on second pair of gloves over the cuff. Okay, and this is for the taking off personal PPE or doffing. First, we should always remove PPE under the guise or colleague. We should remove the apron first, and then we perform hand hygiene, remove outer pair of the gloves, and then perform hand hygiene again. And then we remove the hood, and then we remove the gown, and then remove the face shield, and then we remove the face mask and perform hand hygiene and remove the boots, and then we remove the gloves. And every step on removing the equipment or PPE, we should perform hand hygiene to protect our from any infectious agents.
Yeah, these steps are very, very important, please. Most of the cases of infected healthcare worker is due to that step, breaching the step. Okay? Most
Yes.
of the cases they found during doffing, if you didn't follow the same one with washing your hand between every step, you may get the virus in your hand and put it in your respiratory system directly. So please you need to do one small slide about the sequence. Yes, it is good to show it as a figure, but just write hand wash, mask, blah 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 for doffing and the donning. If you don't have, contact me.
Okay.
I will send it to you. Okay.
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 There are other slides like this. This is for doing on. First, we wear gown and mask and Google glove. This is for removing. We should remove the gloves first, and then face shield or goggles, and then followed by gown and mask and respirator. And
Even
perform hygiene between steps. Yeah.
and even for gown, how
Like
the gown are very important. You must fold it interiorly. I mean, you mustn't expose to the front of it. So you are trying to cut it below the near the axilla and fold it in, not out. So if there is any virus, it will not spread on you or on the area.
okay.
Okay.
Thank you. Understand. Okay, this is the similar guideline on how to putting on and taking off the PPE. This is the link for the video. This is from University Malaya Medical Center. This is for COVID-19 guideline. Should wear what kind of PPE should wear for all staff in all area. Should wear surgical mask and apply for hand hygiene. For direct routine care, from COVID in low risk, facial, surgical mask, non-sterile glove, and gown. For high risk COVID-19, face shield, N95 mask, non-sterile glove, and gown. This is for the during swab sampling, shield, N95 mask, non-sterile glove, and head cover, gown, and plastic apron. This is during a very high risk of COVID-19, shield, N95 mask, non-sterile glove, head cover, apron, including shoe cover. Okay, so basically what my presentation about is prevention is better than cure. Okay, that's all from me. Wait, I think I just want to show a video regarding the washing hand.
Healthcare professionals, it is our responsibility to promote and maintain the health of our patients and to prevent contamination of infections. And the single most important infection control method is hand washing. Okay, I'm going to demonstrate to you the steps of proper hand washing. All we need are soap and water. It can be a faucet using hand or a pedal faucet. Okay, the first thing we have to roll up our sleeves or the sleeves or uniform and to your elbow. Okay, and then remove your jewelries. Then wet your hands with water. Okay. Apply enough soap to cover all hand surfaces, and then the hand palm to palm, and then right palm over the left dorsum with the interlaced fingers and vice versa. Next step is palm to palm with fingers interlaced, and then back of fingers to opposing palms with fingers interlocked. And then rotational rubbing of thumb clasped in right palm and vice versa. And then rotational rubbing backwards and forwards with clasped fingers of right hand in left palm and vice versa. And the last one is rubbing your from wrist to forearm and also the upper hand. And then rinse the hands thoroughly with water. Okay, when there is no more soap in your hand, then dry the hand thoroughly using paper towels. And now
Okay,
your hands are safe.
so that's all. I think that's all from me. Thank you.
There is a nice slide which is demonstrating where the organism may stay if you didn't do a good hand wash. If you try to edit, because usually it will stay in the palm of the hand in the area of the crease. That's why we are insisting to do rubbing of this area by our fingertips. It is very important. Also for the finger, for the thumb, it is the same. That's why you will be convinced that every step of hand washing has its own benefits. Try to edit, it will give you a rationale why you are insisting for all this step, why not just wash directly like that, okay? Good,
Okay,
good. Please, this one to be applied. Any breach for infection control, and any breach for SOP is considered bad at that time, and its results are very bad also. Okay,
Okay.
the next.
Okay, the next one is I'll be presenting about incision of CBD, continuous bladder drainage, or also known as urethral catheterization. So this is the contents, which is I will be explaining about introduction, indications, contraindications, preparation procedure, and also complications. And as for introduction, urethral catheterization is a routine medical procedure that facilitates direct drainage of the urinary bladder, and it is used diagnostically to help determine the etiology of many genitourinary conditions, and also therapeutically to relieve urinary retention, to insert medication, and also to provide irrigation. And it can also be used as in and out procedure for immediate drainage, for example, in during surgery, and also it can be left indwelling in the patient for a long-term drainage, especially for a patient that has chronic urinary retention.
I think you can add also intermittent drainage, which is very important, indicated if you have inertia or atonia of the bladder. If we didn't teach the patient or the family to do intermittent, it can lead to renal failure with time. Just as a title, intermittent drainage of the bladder. Okay.
Okay, Doctor. Okay. For indications, for diagnostic indications, it is indicated to collect uncontaminated urine specimen, especially for patient that is not yet toilet trained and we cannot catch the clean midstream urine, and to monitor urine output, also for imaging of the urinary tract. And it is also indicated therapeutically for acute urinary retention, for example, if there is blood clots, for chronic obstruction that cause hydronephrosis, and for initiation of continuous bladder irrigation, intermittent decompression for neurogenic bladder, and also for hygienic care of bedridden patient. And this urethral catheterization is contraindicated to patient that has traumatic injury to the lower urinary tract, acute pelvic fracture, recent genitourinary surgery, and genital abnormality. And if this kind of patient still need to do this procedure, we need to consult with urologist before performing this procedure in this kind of patients. And then for the preparation, the first one, we need to gain consent from the parents or the patient, and we need to explain the procedure to the parents and if the patient and to the patient if possible, meaning that if the age of the patient is appropriate and they can understand what we are saying, and we need to prepare the equipment. And as for the equipment, the first one that is plastic apron, 2 pairs of sterile gloves, sterile water-filled syringe that later we will use for inflation of the catheter balloon after it is inserted, and then saline, lidocaine anesthetic, lidocaine 1% anesthetic lubricating gel, urinary catheter with appropriate size, 4 French is the unit of the size of the catheter. 4 French for less than 3 kg body weight patients. 6 French for more than 3 kg patients. And as for older children, we can use Foley's catheter that size 6 to 10 French. And catheter pack, that include the cotton wool balls, sterile gauze, sterile drops, absorbent pad, and a small pot, or this jelly pot, catheter bag, and also a urine collection bowl. And this is the types of the catheter. Usually we will use the straight tube catheter. Today tube catheter usually is for a patient that has prostatic obstruction. And then this three-way catheter is used for irrigation. And next, as for the procedure, this is basically the procedure that we need to perform. And for the first and second one, which is the first one is position the patient. This is for both male and female patient. The first one is we need to position the patient, whereby we need to place the patient in supine position with knees bent and hips flexed, or in frog leg position. And then the bed at appropriate height for us. And then if there is any soiling, we need to clean the genital area with soap and water first. And then we need to unpack the equipment. First, we need to wash hands or perform hand hygiene, and then open the catheter pack from the corners without touching the inner surface. This is to preserve the sterile. And then we need to wear gloves. The next one is we need to clean the genital area, and as for male, we need to hold the penis with non-dominant hand using sterile gauze. And for uncircumcised patient, make sure that the foreskin is retracted first, and then use dominant hand to clean the urethral meatus with cotton ball using this single stroke method, and with the direction away from the urethral meatus. And then after that, we discard our glove, perform hand hygiene or wash hand, and then we need to wear new gloves. And then put drap over the genital area, not covering the penis, and then place the sterile urine collection bowl below the penis. And as for female, we need to part the labia with a non-dominant hand, and then using the dominant hand, we also need to clean the urethral meatus with cotton ball, also using the single stroke method, moving downwards and surrounding the region. And after that, we need to discard gloves, perform hand hygiene, and then wear new gloves. Put drap over the genital region, not covering the meatus, and also place sterile urine collection bowl. And then the next procedure is we need to, after cleaning, we need to give a local anesthesia. And as for male, we need to inform the patient, warn the patient that the gel might sting initially, and then they will feel numb quickly. And then hold the penis vertically with non-dominant hand, and place the syringe of anesthetic gel that contain lidocaine, of the lidocaine anesthetic gel into the urethral meatus with dominant hand. And then empty the syringe slowly and steadily, and hold the penis vertically to ensure that the gel stays within the urethra. And then we need to wait up to 5 minutes for the lidocaine to take effect, for the local anesthetic to take effect. And also the same for female. First, we need to inform the patient that the gel might sting initially, and then they will feel numb. And then part the labia with non-dominant hand. Place the syringe of the anesthetic gel into the urethral meatus with dominant hand, and empty the syringe slowly. And then we also need to wait up to 5 minutes for the gel to give effect. After giving the anesthesia, then we can insert the catheter. As for male, the first step is we need to remove the tear away portion of the wrapper without touching the catheter. This is to prevent us from contaminating the catheter. And then hold the penis with non-dominant hand, and then inform the patient that we are about to insert the catheter, and then insert the catheter slowly while gradually remove the wrapper to expose the catheter. And then we can feel some resistance when passing the prostate, and the patient may experience discomfort. And then after reaching the bladder, the urine will begin to drain. And after the urine drain, so this indicates that the catheter reached the bladder. Then after that, we can inflate the balloon with the water-filled syringe, and then remove the syringe, and withdraw the catheter gently until the resistance is noted. And then for uncircumcised patient, we need to replace the foreskin and then attach urine collection bag at the end of the catheter, and we need to position the bag below the patient. And as for female, also we need to remove a tear away portion of the wrapper without touching the catheter, part labia with non-dominant hand, and then insert the catheter slowly into the urethral meatus. Basically, it is just the same with the male. And then after reaching the bladder, inflate the balloon. Basically, it's just the same. And then until we need to position the bag below the patient. And if there is significant resistance while inserting the catheter and patient is uncomfortable, remove the catheter and ask for specialist help to review the procedure if the patient is really uncomfortable with the procedure. And then the last one is complications. There will be inability to catheterize, and if we are not careful enough or not gentle enough, it can lead to urethral injury and hemorrhage, also false passage whereby the catheter is pushed through the urethral wall, and also it can lead to urethral strictures, infection, psychological trauma for the patients, and also paraphimosis for male, whereby the retracted foreskin cannot return to the normal position. Okay, I think that's all for me. This is the references.
Okay. Okay, the issue for procedure, you need to do it many times, okay, to be experienced for that. It is the same if you are surgeon, you need to count like 1,000 operation to be very clever like that. So with time, all this will be very simple, inshallah, in practice. Do you have any questions? Go for the second presentation, for the next one.
Assalamualaikum warahmatullahi wabarakatuh. Can everyone hear my voice and see my slide?
Yes.
Alright, thank you. Okay, so Bismillah. So my name is Nurul Hanan, and I will be presenting about the ECG. Okay, so this is the content. Okay, so for the first introduction, so ECG or electrocardiogram is used to measure or record electrical activity of the heart, and this procedure is safe, painless, and also quick test to see if to look for the heart rhythm, and also to see if there is any heart abnormalities. Okay, so for the indication of ECG, so we can do ECG if there is a symptom of if there is loss of consciousness or seizures, cyanotic episodes, symptom of chest pain on exertion, and also drug ingestion, and also if the patient has known cardiac history or family history of sudden cardiac death, and also to evaluate heart rhythm abnormalities such as arrhythmia. Okay, so for the contraindication, electrocardiogram has not absolute contraindication, although some maybe have a reaction. Some children may have allergic reaction to the adhesive used on the leads. So for the ECG leads, there are 10 electrodes that are required, and that will be 4 electrodes on 4 limbs and 6 electrodes that will be placed on chest. So okay, so this electrode will produce resulting in 12 leads. So there will be 3 bipolar limb leads, 3 unipolar limb leads, and also 6 precorded or chest leads. V1 until V6. Okay, so these are the picture of the positioning of the electrode. So for the procedure, first we have to prepare. So we need to obtain informed consent. So we have to explain the procedure to the patient and obtain their consent. And then we should
I think Hanan is stuck. Her internet is not stable.
Okay, can you present for her if she can send you the presentation? It may be more easy for her, just speak.
I suggest if we continue with the net presenter first.
Okay.
She's available then.
You can ask her to send it to you so she can only comment on the slide after that. Okay.
Okay.
Should I proceed first? Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Aiman. I'm going to present about blood pressure measurement. So this the indication to do the blood pressure measurement. So basically, we do the blood pressure measurement in Malaysia to all children and adolescents as a screening program for more than 7 years old. But in US, they do the screening program after 3 years old. And then we do the blood pressure measurement in children less than 7 years old and infant with high risk of hypertension, such as history of neonatal complication that require neonatal ICU, and then chronic heart disease, recurrent urinary tract infection, hematuria, proteinuria, non-renal disease, family history with renal disease, solid organ or bone marrow hypertension, malignancy, evidence of raised intracranial pressure, and also if the patient need to take medication that can raise the blood pressure. Next.
So I must you need to rearrange this slide to be it is indicated for any patient needs like high dependency unit or ICU, okay, but it is a part, routine, vital sign. Don't forget that vital signs, its name is vital. So it is vital for any patient.
Uh-huh.
They are trying to make it less than even from 3 or 4 years, can be as a routine, okay? So we must take care because blood pressure are very important, but it is more indicated with that one, okay?
So
Patient in critical condition needs high dependency or ICU level or care or severe disease, okay? And it is a part, okay, of a vital sign recommendation, especially from fourth year.
so I should add the vital signs.
Yeah, vital sign are vital,
Oh, okay.
okay?
So for the equipments, we need the stethoscope and the manual blood pressure cuff with sphygmomanometer, and then automated oscillometric device and cuff. So in order to make sure that we got a precise blood pressure measurement, so we have to ensure the size of cuff. So how do we make sure that the cuff is suitable for the patient? We have to make sure that the bladder size is 80% of the arm circumference, and then the vertical bladder cuff has to be 40% of the arm circumference. So make sure that it is covering the arms of the patient perfectly. And let's say if we use the cuff which is smaller than the patient measurement, so we might get the blood pressure higher than the actual measurement. And if we use the larger cuff as compared with the patient proportion, so we might get a lower blood pressure. So this is the procedure for manual blood pressure measurement. Call it as auscultatory blood pressure measurement. First, we have to make sure that the patient sit comfortable and the leg is uncrossed and the feet is resting on the floor for 2 to 5 minutes. So before we go further for the procedure, we have to make sure that the patient has to take a rest 2 to 5 minutes before we take the blood pressure measurement. And then we have to make sure that the patient didn't take coffee or they do exercise 30 minutes before we take the blood pressure. And then we have to make sure that there's no patient with free clothing, which is there's no long sleeve, or if there is long sleeve, we cannot just take the sleeve up to the arm, because we want to make sure that we take the blood pressure precise. And also the position of the arm should be at the level of the heart. So for example, we put the patient's hand onto the table, which is stated in the second procedure, which is the arm should be supported at the level of the heart, and then just slightly flex at the elbow. The third, and next, we place the BP cuff, blood pressure cuff, with the bladder midline over the brachial artery pulsation. So this is in the figure. And then to determine the inflation level, palpate the radial artery. So what is meant by inflation level? So it is like we predetermine in what extent we should inflate the bladder. For example, we palpate the radial artery, and then we rapidly inflate the cuff until the pulse disappears. So we know that. So because we don't want to inflate up to 300 millimeter mercury, because it is too high. We just want to predetermine in what extent that we have to inflate the cuff. So after we get the inflation level, so read the pressure of the manometer, and then we add 30 millimeter mercury to it. So for example, we palpate the radial artery, and then we rapidly inflate the cuff until 160, and then we didn't hear any pulse from that. And then after that, we add 30 millimeter mercury to it. So it will be 190. And after that, we deflate the cuff and wait for 15 to 30 seconds. And then we do the same thing. We place the cuff back at the position, and then we place a stethoscope over the brachial artery. So at this point, the carrot cough sound are heard using the bells of the stethoscope. I will explain a little about the carrot cough sounds. And then we have to make sure that the proper seal is obtained. The next step is inflate the cuff rapidly to predetermine the inflation level. And then we turn the bulb screw counterclockwise to deflate slowly at the rate of 2 to 3 millimeter mercury per second. So these are the 5 carrot cough sound, where the first we have to make sure that we heard the first sound, which is the phase 1, where the systolic sound is heard. And then the diastolic sounds begin to start at phase 5, where the sound is ceased. So there is no sound you can hear at phase 5. So that we can take the systolic and diastolic blood pressure. So note that the level at which sound at least 2 consecutive beats, which is, we know that this is the phase 1 of the carrot cough sound. Then this represents systolic blood pressure, and then we continue to deflate until the sounds become muffled and disappear. So this is carrot cough sound, and this represents diastolic blood pressure. So after that, we deflate the cuff rapidly and record to the nearest 2 millimeter mercury, and record what arm that we use, and then the position and the cuff size. For automated device blood pressure measurement, which is oscillometric, the same thing we do. Patient have to sit comfortably for 2 to 5 minutes, and then the arm should be supported at the level of the heart. And then we place the automated oscillometric cuff on the arm, initiate the automated device, which made it inflate and then deflate. So we will automatically get the systolic and diastolic measurement. And then we record the blood pressure, MAP, mean arterial pressure, arm use, arm position, and the cuff size that we use. So if we want to repeat the measurement, make sure that we have to wait for another 2 minutes before we start another measurement. So I've stated here is my reference. So you can go to YouTube to see how they take measurement for blood pressure in toddlers and the carrot cough sound. Sorry?
Where is normal blood pressure for children?
Oh. The normal blood pressure depends on the age of the.
This is the first page in your book, pediatric protocol. It must be added.
Oh.
And you must add also one about the centile of the blood pressure. I mean, what is the 5th, what is the 10th, what is the 9th centile? Very important, okay? To be So at least you have the ability to assume near accurate how is the blood pressure at that moment. Okay, so it is very important to add both of them to your presentation.
So we actually in order to know that the patient has a hypertension or not, it depends on the age of the patient.
You see here, Ayman, we have in every situation we have third decile, then fifth, then 25, then fifth, then 95, then
Oh,
like that. Okay, we put here the most common, which is if,
oh.
if in your practice of medicine
Mhm.
you have two standard deviation, I mean less than 10, it will consider hypotension. If you put more than 90, which is two centile, which is the 95 and the 98, it will be considered hypertension. That's why you must document one centile figure and this important table.
So actually there is a, are you saying that there is a more simplified blood pressure that we can refer in order to know that the patient has hypertension or not? Is that what you mean? So I'll explain a bit about how do we can consider that the patient has hypertension or not. So normally in hospital we take a blood pressure using the automated or oscillometric blood pressure device, and then if we know that the blood pressure is more than 95 percentile, which is here. Can you hear me? Can everyone hear me?
Yes.
Okay.
Yes.
More than 95 percentile, which is here, and then let's say the patient is age of 1 year. So here is the 95 percentile, and then if it is more than that, so we have to remeasure 2 times, and then if the result is still the same, which is more than 95 percentile, so we call tertiary method, which is the manual method, and then if again it is more than 95, 90 to 95 percentile, so that's what we can diagnose the patient has got hypertension. And then there's another method that we use in order to avoid, or we call it as the white coat effect. We call it as ambulatory device, which I not state here. Ambulatory device is the device that we attach to the patient. It's just the same. We put a cuff and there's a tube that attached to the ambulatory blood pressure measurement device, and then we take the blood pressure for 24 hours, over 24 hours. In the day, we take every 15 to 30 minutes, we take the blood pressure. And then in night, we take for every 30 to 1 hour, because we want to know the variation and then to eliminate the white coat effect. And then we want to know the effect of the medication that we give to the patient. So again, if the patient is age 1 to 30 years old, the normal is below the 90 percentile. or it is below than 120 to 80. And then in elevated, it is more than 120. In stage 1 hypertension, it is 100 and more than 130 over 80 for the diastolic, 239. So it's between 130 to 139. So that we call it as a stage 1 hypertension in patient with at the age of 1 to 13 years old. If it is more than 30 years old, it's actually the same, but we didn't refer to the percentile. Is that clear? Any question?
So we can understand now how to interpret the blood pressure, which is a very important of your part of presentation you need to complete. Also good that you refer to the white coats, which can cause in many persons, even doctors themselves, sometimes they are afraid of measuring the blood pressure.
Mhm.
And there is another important point, which is the intra-arterial blood. The patient in ICU condition, and you have arterial line, you just connect it and it will be permanent, and this is the top accurate one.
Mhm. Yes, actually we have direct and indirect method. So what the doctor said that about we directly put the catheter into the artery, we call it as the direct method. But this is the most precise blood pressure that we can take from the patient, but this is invasive.
Okay. Noor, Hanan is around or not?
Yes, I'm here, doctor.
Okay.
Sorry, I just got disconnected. Should I continue?
Yeah, but you are presenting the ECG, yes?
Yes.
You must put your indication. You can come to the first slide again.
All right.
You can divide it either cardiac or extra cardiac. It's not number one for the indication of the ECG is the seizure or loss of consciousness. It is considered, okay? So cardiac or extra cardiac. So cardiac, we are speaking about chest pain, about arrhythmia, about cyanosis, like that, positive history. And then some case which may need seizure like that, ECG like that, okay?
Okay.
Okay. Yes, continue, Hanan.
All right. Mm, Okay. So for the electrode placement, for the ECG. Okay, so as I said before, there will be 10 electrodes that will be placed, 4 on the limbs and 6 on the chest. So for the limbs lead, we should put on the right and left arm and also right and left leg. So for the limb leads, we must make sure that we put it on the limbs and not on the torso. So for the arm, we can put it just above the wrist, and for the leg, we can put it above the ankle. So for the chest, first, to place the electrode, first we need to palpate from the sternum, and then we go down until we feel the sternum joint, and then we palpate the second intercostal space. After that, go to the third intercostal space, and then for the at the fourth intercostal space, we put the V1, just at the right of the sternum. Then, at the left of the sternum, at this the same line, just parallel, we put the V2, and then we put the V4 at the fifth intercostal space at mid-clavicular line, and then between V2 and V4 we put the V3. So, and then after that we put the V6 at the mid-axillary line at the fifth intercostal space, and then between V4 and V6 we put the V5. After that, for infants or toddlers, because there will be difficulty to fill the intercostal space, we can just use this guide. So for the V1, we put the V1 at the nipple line to the right of the sternum, while V2 parallel to it at the left of the sternum. And for V4, we put at below the nipple at mid-clavicular line. And then between V2 and V4, we put the V3. And then we put V5 at the anterior axillary line at the same level as V4. And then V6 mid axillary line at the same level as V4 and V5. So you can see here the placement on the infant and on the baby. Okay, so for the pediatric ECG, some abnormal finding that we find on the adult ECG may be considered as normal in children's ECG. So for example, rightward QRS axis, right axis deviation is considered normal in newborns and in children, and there will be T wave inversions in B1 until 3. So this is considered normal in children ECG, and there might also be RSR pattern in B1, and in children ECG there will be shorter PR interval and shorter QRS duration. Okay, so for the neonates or newborn ECG is similar to ECG of adult with right ventricular hypertrophy. So these are some of the normal findings in children's ECG. Okay, so for the normal heart rate in children.
Hit full screen, please.
Okay. Okay, for the normal heart rate in children, for newborns, the normal heart rate is between 120 to 160 beat per minute, while for infant or 1 year or less than 1 year, usually the heart rate is just the normal heart rate is below 140, while for children below between 1 to 5 years old, the normal heart rate is below 120 beat per minute. So while child age 6 to 12 years old, the normal is 80 to 110. And then for children older than 12 years old, the heart rate is similar to adult normal heart rate. So this is the ECG of a healthy 2 years old boy. So you can see the heart rate is 110 beat per minute, which is normal for his age. And then there is a dominant R wave at the V1 until V3. And then there is RSR pattern, and there is also T wave inversion at the V1 until V3, the T wave inversion. So this is a normal ECG for a healthy 2-year-old boy. I think that's all.
I think you add to need also adding one slide about how to interpret. I didn't need a lot of example, just we must be able when we see ECG to comment like number one, as you said, about the rate, about the rhythm, then about the axis, then about the B wave, then the QRS, then about the T wave. And in every point of this, we must know what to measure. Okay? It is very important. Yes, we need to know how to do ECG, but also we need to know the general line which you are looking for it with just simple examples at the start. Okay, Hanan?
All right.
Very important because you need to redemonstrate the BQRS and tell us this one will show us the problem with the atrium. If it is right atrium, it will be like that. If left atrium, it will be like that. QRS is related to that. What about the Q wave is related to the ischemia or like that. So it is very important not to know the shape of the ECG and to comment only on rate or rhythm. We need to comment about 8 parts of the ECG at least. Must document. Please, all current and the previous correction must be recorrected and resend it to me, please. Okay?
Okay, doctor.
Okay. Is there any more presentation or?
Yes, Doctor. I'm the last presenter.
Okay, you are welcome. Who?
Let me see. Slide. So can everyone hear my voice?
Yes.
Okay, so Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. I am Ainul Hayati Mutisham with mentoring number 1811106, and I will be presenting about how to measure the height, the weight, and the OFC, the occipitofrontal circumference or the head circumference of pediatric patients. So first of all, the length of or the height. Basically, for children young 2 years old or younger, we should measure the length because they cannot stand properly. For children older than 2 years old, we should measure the height, the standing height. Okay. So for to measure the length, we need a measuring board where there should ideally be 2 people to assist, one to hold the patient to position the child and one to measure the length of the child. Okay, so hair ornaments or hairstyles such as braids or any hair clips should be removed because it can interfere with the measurements. And also the child should be placed supine on the measuring board where the child is facing straight to the ceiling above. Okay, and the measurement should be reported to the nearest millimeter or 0.1 centimeter. So for children older than 2 years old, we should use a stadiometer in the picture here, where it is a standing ruler. Before the procedure, we must remove any shoes or slippers or any orthopedic braces such as leg braces, if possible. And the child should stand on the stadiometer with the head and the eyes looking straight ahead, with the heels together flat on the floor, touching the back plate of the stentometer. The shoulders should be relaxed and the arms should be loosely by the side of the patient. And the nurse or the doctor should put the horizontal headpiece in contact with the superior part of the head to measure the height of the patient. And we should read the measurement to the nearest millimeter, also 0.1 centimeter. Okay. So next, the weight of the patient. Similar also for children, for patients 2 years and younger, we should use the baby is still small, so we should use an electronic baby scale in the picture here, where we put the baby here without clothing or without diaper. If the patient is still small, is infant, and the measurement is recorded to the nearest 0.1 kilograms or 100 grams. So for children older than 2 years old, we should use a beam balance or digital scale where the patient will stand properly on the scale, wearing only light clothes, and remove the shoes and slippers and the pockets empties if there is any pockets and in the pants. And the measurement is recorded to the nearest 0.1 kilograms. Okay. So in the case of a distressed child where the child has some problems, the guardian or the carer should stand with the child on the should stand with the child should hold the child while waiting to weigh the child. But we must subtract the carers or the guardian's weight to determine the child's weight. Okay. Next, the third part is the OFC or occipitofrontal circumference. It is also known as head circumference, where it usually reflects the brain size of the baby. So it is for children up to 36 months old or 3 years old, because from 0 to 3 months old, this is when the highest or the greatest brain growth occur. Like 80 to 85% of the brain size is until 3 years old. So the equipment we need is a non-stretchable, flexible measuring tape, like in the picture, where we wrap the tape around the from the supraorbital ridge to the occiput here, from the supraorbital ridge between the eyebrows and also the hairline, and to the occiput at the back. So we wrap the tape around the widest possible circumference. This is when the patient's head is abnormal size. We should wrap the tape around the widest possible circumference, especially from the supraorbital, if possible, at the supraorbital ridge to the occiput, like what this nurse is doing. Okay. So we must remeasure, if possible, we remeasure the OFC 3 times and take the largest number and report it to the nearest 0.01 centimeter, and we plot on the standardized growth chart. Okay, so this is the typical head size of a baby. This is when a baby has microcephaly, which I'm sorry, this this is this is terbalik. Okay, so macrocephaly is 2 standard deviation above the mean. On the growth chart, we can see a line. This that is the z-score line or the mean. If it is 2 standard deviation above the mean, it is macrocephaly, which is the baby has a big abnormal big head. If it is microcephaly, it is it is smaller than the typical head size. It is 2 standard deviation below the mean. Okay. I'll correct this later. So important notes for the OFC or head circumference. The OFC can be affected if the patient has thick hair, because we like in this boy here, or if there is any cranial bone deformation such as hyperostosis or craniosynostosis, which when the patient has a premature ossification of skull sutures, and the patient has a normal brain size, but the skull is abnormal. Okay, so OSIS should also be measured in older children with abnormal height and also weight. Okay. So these are the growth charts. Growth charts are a series of percentile curves that illustrate the distribution of selected body measurements in children. Like I've mentioned before, the length or the height, the weight, and also the BMI of the children. For less than 2 years old, we use the WHO growth chart, and for the 2 years and older, we use the CDC growth charts. These are the Malaysian growth and developmental growth chart for the pink one is for girls, the blue one is for boys, and this one is the preterm for the preterm babies. Okay, so these are the growth charts. For the boys are the blue ones, and the girls are the pink one. This is berat untuk umur or weight for age. This is for the length. This is for the height. This is similar, but for girls. These are for the head circumference until 36 months or 3 years old. And also there is also one for the BMI, BMI of the patient. It is plotted against the age of the patient in weeks or in years for 2 years and older. So from pediatric protocols, these are the normal or the ideal anthropometric measurements for the weight, the height, and the head size of according to the age at birth, 6 months, 1 year, 2 years, until the puberty. I think that's all for my presentation today.
Yeah, this is a good example of, can I see the chart again? The centile chart? Yeah.
This?
Yes, the previous one. Okay, for boys, for both boys, yeah. The most important point here is to be professional in even simple things in your medical life. Suppose someone is very hairy, he just put the baby on the scale and said 2 kilos like that. It is not good, because the importance of this growth chart, which is known as centile chart, is to put repeated measures. I mean, I measure the child at 2 years, and when he comes to me again and 2 years, so I must know that this child needs to good growth at least 6 centimeters. If he didn't got it, it may be a problem. So if the previous one just to do his job unprofessional, will make everything not good. Okay, so please do every part in the medicine, even getting simple one, like your colleague speak about now, Ainul Hayati, she is speaking how even to measure the height. If a small baby, he must be recumbent, and one alone cannot measure, because we need to extend his knees, his hips, like that. And if it is longer than that, even how the child can stop up in front of the scale, and which part of the body need to touch the back of the scale, from the head, the shoulder, the buttock, even the heel, which is very important. And how if the child even put his head, he must forward vision, he mustn't bend his head or extend or like that or flex, which can affect the height. So the standard are very important, which will give us how to check the growth and the development of the child. Okay, so it looks simple for blood pressure. It looks simple also for the weight, height, and head circumference, but it is very, very, very important. I think you have in this cauliflower simple example of dropping through the centile, okay, which is like familial one or constitutional delayed growth, you can just add 1 or 2 figures out there. Okay, so we'll build in our mind the importance of serial measures. And I used it to tell you an important example. I may see one child, I put him in the centile chart, he is a 50 in the 50 centile. Okay. When I follow the previous one, I found the previous baby is only on like 25th centile. So I'm going to tell the family, oh, wonderful, your baby start now to regain weight, is very good, just to continue normal diet and blah, blah, blah. But I may found that this child before is on 9th centile. I tell them I am afraid because any crossing, remember that, any crossing more than 2 centile, considered pathological. You must search while this patient cross 2 centiles. Okay? So it is very important to include some of this serial in case of constitutional, in case of hypothyroidism, in some other diseases. It is, if you just write it, you will find a lot. Okay? The other point, do you need to ask any questions for Hayati or for me? Can I see the references again? No, this is not the ideal way to write references. Must be one of the group write how to write the formal reference during according to the formal one. You must write who is the author, at which chapter, and then at which book, and then you are writing the edition and the date. All this is very important, please. And you need to add all together in one PDF file after correction and send it to me. Sometimes we need to guide the coming generation after you how to prepare it. Okay? So your name must be clear, also added, because it's yours. Okay. At the end, inshallah, you are coming soon to our units. So you need to be prepared. If you hear about any procedure, just be hurry to attend. Even year 5, attend with me in the clinic. We are able to do a blood sample, to do urinary bladder drainage, to do a lot of things, blood culture, everything, nebulization. All this can be done even in outpatient. So don't be hesitate to attend, inshallah, the procedure soon. See you. Assalamu alaikum wa rahmatullah.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Assalamu alaikum.